let's get underway. Let me start by welcoming a world record number of people to this presentation. We normally count ourselves lucky to have 20 or 30 people, but we have over 300 have registered for this event. And thank you very much for doing so. I'd like to begin by acknowledging the traditional owners of the land. I'm on Gadigal country of the Eora Nation and pay my respects to Aboriginal elders past, present, emerging, and very much to any Aboriginal people who are dialed in this evening. This presentation is, of course, to talk about the changes that we're anticipating in the opiate treatment program, which will really have a significant impact on our work clinically. Can I ask that everybody puts themselves on mute and only unmutes themselves when they want to address everybody, because with so many people, background noise is quite disruptive. I also want to welcome Stephanie Hocking from the ministry, who has been working, I think, night and day on responses to this program, and who deserves our great praise and thanks for that, but who will also share some of her inside knowledge about what's going on and what we can do. So hi, Steph, and welcome.
Thanks, Paul. I've also brought along Christina St. John, who is the absolute brains trust in all this.
Okay, so welcome to Christine as well. So I'm going to start. What I wanted to do was to start with an introduction to what's happened, to speak quite briefly, and then to highlight a couple of recent resources that have updated things quite significantly. Basically, the Commonwealth has placed two significant update documents posted overnight onto their website, and we've pasted a link into the chat. So I encourage anyone who wishes to look at the first couple of items on the chat, and that's going to be a link to a lot of documents that are available. As we know, community dosing for the opiate treatment program has been a financial burden to patients for as long as the program's been in place, 30 years. And there have been a number of attempts to address this. And most recently, a post-marketing survey led to a recommendation to the PBS, which accepted the recommendation that OTP should be placed onto the Pharmaceutical Benefit Scheme. And as a consequence, that was done and included in the budget. So the general community heard about this was as a small line item within the budget on the 10th of May, and that this comes into place on the 1st of July. It's now the 20th of June, so that's quite literally Saturday week. So it's a dramatic, major shift. It's largely a beneficial shift, but it's happening at very short notice. So many changes are being introduced into our program at lightning speed. So this is a presentation that Deborah Zador gave, providing an overview, and I'm just going to pick the eyes out of this by way of an introduction. Almost half of clients on the OTP in New South Wales pick it up through a community pharmacy. And the changes proposed will be a major benefit to those clients. Concession card holders will pay $7.30 a month, and Medicare card holders will pay $30 a month. As I understand it, those numbers are going up for the next financial year, but only slightly. In return, they will receive their medication for the entire month through that PBS pharmacy, whether that includes takeaways or daily dosing, according to what is prescribed and dispensed from the pharmacy. Pharmacists, in return, will receive reimbursement for the cost of the medicine, they'll be paid a markup fee, dispensing fee, a dangerous drug fee, and a stage supply fee if applicable. And when you add it up, the estimated fees that we calculate are in the range of what the pharmacy are currently receiving from patients currently. Now, since this is a fixed fee, and since pharmacies around New South Wales have the right to charge separate fees, it's not exactly the same, and it won't be the same for everyone, but pharmacists that accept this fee will not be allowed to charge anything extra. There will also be a fee for the dispensing and administration of depot buprenorphine in community pharmacies as part of these reforms. And this will replace the New South Wales program, which has been encouraging and providing some funding support for that activity. Now, in public clinics, the situation is slightly different. About 20% of clients receive their OTP in public pharmacies. The patient experience will not change very much in public pharmacies. So they will continue to operate, they will continue to offer treatment, but in back of house, there will be substantial changes to the ordering of medication by the hospital, the public clinics, and in the prescribing and in the way that the doctors prescribe it. There will be new supply chain arrangements, and there will be this move from medication orders to PBS prescriptions required. There will potentially be a $7 dispensing fee from public clinics, but the latest word is that that will not be required. It is, we'll hear from Steph shortly, but that seems to be where we're at. Correctional facilities, about just over 10% receive their dosing from correctional facilities, and we will expect that they will not be charging co-payments, and largely from the patient journey, it will be a similar process, and back of house, there may be actually less complexity because correctional facilities are already able to claim PBS benefits for a number of specialised medications that they use. About 1 in 10 receive their dosing from private clinics or from non-PBS pharmacies or from GPs or private medical practitioners. And these are going to be at the greatest risk. There is even a risk that some of these clinics or businesses will close due to the lack of financial viability. And a recent change has been that the Commonwealth has allowed that there will be an extension of the existing medication ordering system for private clinics that will operate until the 30th of November. So for the next few months, non-PBS dosing programs that include the private clinics will be able to continue ordering medications that will assist them to stay, frankly, in business, to stay operating, but they will still be at a financial disadvantage because there is no support for the administration or dosing fees. They will either not collect fees or they will have to collect fees, and then the patients will be disadvantaged compared to receiving treatment in a PBS pharmacy. So that's the overview, and I thought at this point I would stop sharing. I would invite Stephanie if she wants to make any specific comments, and then throw it open and invite people to ask questions and or put things into the chat. Stephanie, did you want to make any general comments?
Sure, Paul. There are some things that are a little bit up in the air at the moment. We're doing the very best that we can to negotiate to ensure at the end of the day, the number one priority in all this is that no one goes without treatment. That is the absolute priority. So we're having community of practices with the private clinics, with corrections, with private correctional facilities, with the SLHDs, with the NGOs, with Aboriginal community controlled organisations, pretty much everybody who is affected. And I'm pretty sure this Monday, Joe Zelinga, who's a pharmacist on our team, is also working with PRU and the Guild to run a pharmacy community of practice as well. It's just to sort of share insights and to try and get everybody as up-to-date information as we can, because that's our objective in all this, is to keep everybody as informed as we can, to sort of stop the rumour mill, which is quite challenging because some of the information has been quite slow, as most people on this call would know.
I would perhaps turn to the questions that are in the chat, because there's a few of them here. First question is about transitional arrangements. Transitional arrangements, again, have been challenging for us, but these are at least in part covered by the advice received from the Commonwealth, which is up here in the first link that I circulated. But in a nutshell, I don't think you're going to entirely like this. We've been advised that paper prescriptions written before the 30th of June will count as prescriptions that pharmacists can claim from PBS. But we have also been advised that electronic prescriptions or e-scripts will not count in this way. So there's some reason for that, but none of us know what that is. But so the information sheet suggested that people could, if they wished, start writing any scripts that you generate between now and the 30th of June. They're suggesting write them out on paper, because then they will be valid for the next couple of months. And you save yourself having to reissue the script shortly after 1st of July. And paper scripts will be valid, but electronic scripts, e-scripts, will have to be reissued, I'm afraid. Yeah.
Sorry, it's Emery Cortez from Salamander Bay. I've got 250 odd places on my program. About 220 of them are filled at the moment because there've been retirements by the bucket load up here in the Hunter Valley.
Yeah.
I spoke to the Ministry of Health about half a year, 3/4 of a year ago, and they said the safest way to do scripts was paper scripts. Sorry, was electronic scripts, because there was no way that they were going to go anywhere other than to the pharmacists. And now they're saying that those scripts are not going to be valid.
They are saying, let me clarify, that those scripts are not valid as in this transitional arrangement, but after the 1st of July, an e-script is valid.
Okay, fine. So really, basically what we need to do is have the pharmacists ring us, give us a list of however many prescriptions they need after the 1st of July, and any that we do between now and the end of June, we do on paper. Is that correct?
That's what they're saying. That's right.
Okay.
And that's just a transitional thing. After the 1st of July, you'll be able to go back to your e-scripts, and they will be accepted. And I use e-scripts when I can, and I love them.
Yeah, they're great. But they're very good when they come down from the sky. If they don't come down from the sky, then you've got to resend them or whatever. The downside, again, with best practice, for example, is that you have to cancel an e-script to then print a replacement script. So,
oh yeah, I know. It's that's right. If it doesn't go through the first time, or if there's no paper in the printer, it's really annoying. there are quite a few questions, so we should, how will a paper script be converted to an authority script? Does what we've been advised is that if a paper script has a date that is prior to the 1st of July, that it will be accepted for a PBS claim. That's the transitional arrangement. So the script has to be, of course, valid, and it will have an end date on it. And then it will, after the end date, it's not valid and a new script will be required. That's what we've been told.
Can I just quickly add to that, Paul, if you don't
Yeah.
mind? So in the fact sheets that the Commonwealth has very, very recently released, there's all kinds of advice for prescribers on how to work with that transitional arrangement. And there's also advice for community pharmacies on how to then process those scripts that were written prior to 1 July. So we really encourage you to take a look at those fact sheets. They give lots of information.
Yeah. I can't emphasize how many of them there are.
If I'm not mistaken, the fact sheet just says that more information will be available closer to the day about how pharmacies can dispense those. So the information, unfortunately, isn't quite there yet.
I think maybe, are you talking about the fact sheets that were just released like late yesterday?
Yes.
Okay, I thought there was advice on what to do in terms of, how to process them, how to, you have to put an annotation on it and things like that. Is that's the additional advice I was talking about?
Correct me if I'm wrong. What I saw just said that paper scripts will be able to be dispensed as authority scripts from the 1st of July, but the codes and what to do exactly with them will come later.
I think you might have out-of-date information. I can
Okay.
I'll put in the
So-
chat the latest. Yeah.
There
Okay.
has been a PBS kind of opiate dependence treatment web page and with a number of attachments and fact sheets. These have been progressively updated. And so what Christina was referring to was the 2 fact sheets that were posted last night. They're the latest ones. And don't be surprised if there are some more to come. So you've got to keep going back to the PBS website, specifically on the opiate dependence treatment program, where there's a number of links and fact sheets that are being progressively updated.
But we can put those specific fact sheets in the chat.
Oh,
Yep, doing
Christina,
that
can
now.
you do that?
Yeah, the links.
Okay. I'll do
Oh.
that right now.
You can do that right now?
Yeah.
Well, that would be awesome. Now, the other issue about prescriptions is that now that it's going on the S100 list, they will be streamlined authority numbers. And the fact sheet includes the actual numbers. But extraordinarily, the PBS website, as of when I last checked it 15 minutes ago, did not have those numbers on it. So I presume that the PBS website will be updated in the coming days, but it's been a point of confusion, but I'm quite sure that they will be streamlined authority items. And that means that you do not have to ring for approval for each case, but you can just write on your S100 form the streamlined number for the particular product, and then you must prescribe it in accordance with the streamlined authority conditions, but they are not particularly onerous conditions. They're just the kind of conditions you would expect, and it will be accepted. And those numbers are on the fact sheet.
And I'm posting the prescriber one right now, Paul. So
You're
so it's included in the codes that you're speaking about are in the fact sheet I'm just about to post.
I'm just thinking if you could post it, I'll actually pull it up so people can see it. It's torture. Okay, here we go. Fact sheet prescriber. Now I'm going to share screen and then I'm going to go there. And can people see that overview fact sheet? Is that posting?
Yes, Paul.
Okay, so this, wait a minute. So this prescribes the maximum quantities in a single prescription, and this rather strange quantity, 0.84 of a bottle of methadone, corresponds to 150 milligrams daily dose for 28 days, which is the highest dose that you can get on a streamlined authority. And higher doses you will require telephone authority for. A minority of patients will be on higher doses. So that will be a little bit burdensome, but otherwise the streamlined numbers will apply. Here we go. So streamlined authority code for methadone oral liquid will be 14178. And for buprenorphine sublingual, this number, the weekly injections, that number, and the monthly injections, this other number. It's interesting. That's okay. That's how they're doing it. And so, whoops. So those of us who are reasonably familiar with S100 scripts or with authority scripts know that there's a little box where you handwrite in the authority number, and on eScripts where you type in the authority number, and so you'll be putting this number in into that spot. Steph, did you have a comment about that?
No, Paul, you've covered it well.
Okay, so temporary transition. Okay, larger doses need phone approval. Yes. Does the patient have to be part of the program under the PBS? Or if they are happy, are they able to remain private? So that's actually a good question for which I can give a clear answer. So under the rules, you have to satisfy the Commonwealth rules to get PBS medication. But in addition, you have to satisfy the State Department of Health rules to prescribe any drug that the State Department of Health regulates. So you don't have to get State Department of Health approval to prescribe amoxicillin, but you do have to prescribe, methadone, buprenorphine, and those rules are not changing. So that is, inverted commas, business as usual. You have to be an accredited prescriber. You have to meet the patient has to meet criteria for opiate use disorder. You have to fill in the form and send it off to the PRU and get their approval. And so they cannot remain private for prescribing, even though it is covered by the PBS. Yes? Steph, we agreeing? Yes, Steph is smiling.
Yes, that's correct.
So those of you who have prescribed OxyContin in the past will have actually had to do the same thing, whether you were sort of very clear in your mind about it. So you could get PBS authority number for 60 milligrams of OxyContin for a patient. But in addition, you had to get the Form 1 through the New South Wales Health if the person met the criteria for a Form 1. So it's actually not new that you have to meet both state and Commonwealth requirements when prescribing these kinds of drugs. Adrian Dunlop says streamlined authorities relisted. Yes. So I'm trying to get through the questions that are on the list. Does anyone wish to make any comment from a Justice Health environment? I've noticed Darren Smythe is on the line.
Craig's also on the line.
Oh, Craig's on the line.
Yes.
Well, either or both.
I don't work in Justice Health anymore, Paul.
Okay, that's not what I thought you were going to say. Is Craig?
Yep, I'm here.
Ah,
So,
excellent. Thank you, Craig.
There we go.
Yeah, so any questions around how this is being managed at this point in time, I'm happy to take those. I can't see the chat function at the moment to see if there's any specific questions. We're working at the moment to ensure from a Medicare number perspective that all patients within the custodial environment will have Medicare numbers on file. Also for Medicare ineligibles, what we're aiming to do is ensure that any patients that are Medicare ineligible, also there's no disruption to their treatment whatsoever. So we will be covering the costs of any patients who are either already on OAT and not eligible for Medicare, or come into custody, meet the clinical criteria and are being initiated on OAT, and may also be ineligible for Medicare.
Thanks very much, Craig. Are there any other Justice Health relevant comments? I think Justice Health is probably less affected than everyone else. So, and for once, that's a good thing, eh?
Yeah, for sure. And like has already been said, we're trying to approach this as a good news story, and also maintaining business as usual as much as possible. There's a lot still to be worked out in terms of the detail operationally in the back end, administratively, but we are trying to maintain this. Katerina Logios?
Yes, your hand is up.
Here we go. I've unmuted myself. Hello. Yes, I was going to ask, though Justice Health is able to manage people without Medicare, because that's really what we do in all those situations, what will happen when they're released back to the community? What's the, are they going to do anything similar like they have for HIV patients that do not have Medicare cards? Is there going to be some funding?
We have, the advice that we've had so far is that this PBS program is only for those that have a PBS
Eligibility.
rights. Yeah. And so any dosing arrangements for non-PBS, and you know, that includes a whole bunch of people like overseas students and it's not a topic to be ignored. I think we'll have a problem, and I haven't seen any solution raised for that problem. At times they attend public hospitals and throw themselves on the mercy of the public system, and the public system has a strategy for recovering costs of healthcare to those that are not Medicare eligible. In my experience, that cost recovery process is not always diligently followed. Thank God. So it's a grey area.
Okay, but there aren't that many on opioid therapy in community or local health district or private practitioner settings is really what I'm getting from that.
Well, there are some. I've had some.
There are some. Okay, thanks.
I'll just make a small addition to that.
Yeah.
I'll just make a small addition to that, Paul. There's also a policy directive for New South Wales Health around how to manage Medicare ineligible clients. So at least from a public sector perspective, there is a process to follow.
Yes, that's right. But I think it depends on the sorry, just shooing people away. There is a process to follow, but it involves cost recovery. And that would also include medical services and other costs. It's not just the medication. I mean, I think that's an area for us to write down and think about. I don't know how, because medications have previously been available more readily, I don't know exactly how often that has come up as an issue. Next question. That someone's asked, is there a real-time up-to-date list of pharmacies that are signed up?
That's a bit of a challenging one, Paul. That's not as easy to answer.
That's why I asked. That's why I got you to speak to it, Stephanie.
As you can imagine, due to stigma and discrimination, there's a number of pharmacists that do not actually want their pharmacies publicly listed due to trouble in the past, etc. So there's not a up-to-date list of pharmacies that is published, but we can absolutely provide those to LHDs and to the private clinics or whomever else would need to. I guess the list would be specific to the area of the person that's asking.
So under the PBS requirements, pharmacist does not have, if a pharmacist is registered for the PBS, they're registered for the PBS, but under the state requirements, they have to be accredited for OTP. So that question becomes relevant because you can't just send any patient to any pharmacy, even with this PBS listing available. Do we have a pharmacist who would like to comment on whether they think this is going to be wildly popular, wildly unpopular, or make no particular difference to capacity in pharmacy settings? We're concerned about this, and I'm getting different advice.
I wouldn't mind commenting, Paul.
Excellent.
So I think it's fantastic for the patients in terms of affordability. I know for one, I have a very vulnerable cohort, as I'm sure everyone else has the same, and our fees were low. But I also know that many other pharmacies charge more than I was or am. So this would be a reduction in their revenue effectively. So there is hesitancy in whether they will stay in the program in the light of a reduction in their revenue, as well as an increase in their workload, because this is not easier, this is actually making it harder. And come 1st of July, looking at the transitional arrangement, if I had only a handful of patients, then no problem, it's an inconvenience, but we can do it. But I have many, many patients. I have almost 50 patients. So what we're saying is I have to reprocess each script individually, calculate everyone's remaining doses, find the appropriate PBS code for them, and do that on the 1st of July being a Saturday, all whilst also running a community pharmacy and serving everyone else. So that the transition arrangement, whilst it's welcome, it is very cumbersome. And the program in itself, whilst it is an excellent idea for patients, I support it, the revenue is not quite there.
Yes, so I've spoken to a few pharmacies, and I have had pharmacists tell me that it's going to be okay, they're going to stick with it. And then I've had another pharmacist say they're not going to stick with it. We've had a pharmacist interviewed in the Australian newspaper yesterday who is from my local health district area. So we've had different things. I've got Ruth Martin with her hands up and on mute, which is not a good combination, but please.
Yeah, hi, and sorry, it's Rosemary James dialing in under Ruth. Ruth circulated this link about 2 o'clock this afternoon. So I'm a hospital pharmacist, and I support what Nadir said. My suspicions are that a lot of community pharmacies, particularly if they've got a big workload, may not be so welcoming of these changes. And as a hospital pharmacist, we had a meeting this afternoon, we're just learning about this. We're quite concerned about the implications for us, because we have zero resources for this, but we just have to watch and see what's going to happen. But we're highly suspicious that it might increase our workload as well. But just another couple of comments. In New South Wales alone, I mean, the PBS is a national system. But a few years ago, Mike Baird, when he was going for re-election, he made a number of promises, and one was to remove the patient co-payment for HSD medicine, which will be very interesting. We're not quite sure how that's going to, whether that will flow through across New South Wales. If it does, that may mean community pharmacies will be required to submit a monthly report or a quarterly report to New South Wales Health for subsequent reimbursement of that HSC co-payment. Hospital pharmacies in New South Wales haven't signed the previous reforms, but we are able to dispense HSD and PAR medicines, and we don't charge a co-payment, and we submit a monthly report to New South Wales Health, who reimburse us for that co-payment. So there's just a few things, and I'm just thinking also New South Wales Health must be changing their legislative requirements, because at the moment we're not allowed in hospitals to dispense electronic S8 medicines prescriptions. So that may be why before July 1 there's that need for paper prescriptions, because it forces the handwriting of certain details. I'm not sure if that's it.
Thank you very much, Ruth. The next hand up I see is actually Andrew Top.
Oh, hello. Hope you can hear me.
Yes.
So I represent Capital Chemist, of which we do have 23 pharmacies in New South Wales, noting I am physically in Canberra right now. My questions are many. The first one was just asked, the New South Wales reimbursement of co-pays on S100s, which was meant to be, my understanding was meant to be for chemotherapy, but effectively extends to all Section 100s. How's that going to work? Section 100 doesn't have a clear supply chain. It doesn't have CSO obligations. That's the wholesaler's requirement to deliver at a particular price in a particular timeline. S100 doesn't have that, so that's unclear. I did survey our pharmacies, and 100% of the pharmacies that replied, which was about 75% of our pharmacies, are clearly going to reduce access numbers, places, or opt out completely. So there is going to be problems here. And part of that is because there is now an extra layer of clerical admin to do the daily payment side of things through the PPA. I know that isn't yet live on their portal, but you know, we can see what the paperwork's like. We know what they're like to deal with in other places. It's going to be complex. Being paid weeks and weeks after the event is not great. Overall, for most pharmacies, it is a reduction in payment. There are major questions about what I'm terming the recycling of unused doses. At least we've got access to a communal bottle, a virtual bottle of methadone, rather than keeping individual patients' bottles. But if they've got a variable dose, or if they don't pick up, do we need to reprocess the prescription at a lower level? Do we need to somehow store their unused doses separately for disposal? And everybody here who's a pharmacist knows that disposal of Schedule 8s in New South Wales is very challenging. It's difficult to do. And there is actually currently a shortage of methadone. I know pharmacies in our group who are going to run out tomorrow, on Thursday. And we don't have a solution for those. This is a disaster. And whilst I support it, 100% support the concept of bringing this into the PBS, maybe a little bit of consultation with people who actually make the methadone magic happen would have been good if the Federal Health Department is listening to this today.
Well, I'm just wondering if the Prime Minister is on this call, but I'm thinking not. So
if he was, he would just roll out his standard form letter that we've all received, because I guarantee everyone here has expressed concerns to their local members, and the response is lacking. Anyway,
I totally agree, and we've organised this session, not to praise the government, but to figure out how to navigate the system. And I have no doubt that in response to what you're saying, that firstly, I don't doubt for 1 minute that some pharmacists will reduce or even opt out. I think it's also possible that some will opt in. I also think that those that stay in the program will have to navigate all of this stuff, and then they may as well have a reasonable caseload, because the revenue comes from the caseload. So once you've figured out how to cope with it, there may be some who increase their caseload. And I'm not making this up, 2 chemists in my area who've said that they are keen to increase their caseload. So I think there are swings and roundabouts. It's not all bad.
Pharmacy can't be put in a position where we accidentally are forced to break the law and I'm sort of referring to the recycling of unused doses, to make this work. We cannot be put in that position, and I genuinely fear that the lack of clarity on some of those elements is going to put us in that position. But I will mute myself and leave it to other people now.
No, but Andrew, I think we should take up this issue of disposal of doses, and we do have senior people from the New South Wales Health online, and so they'll take that away as homework for us all, because we are trying to navigate the situation. We're not just trying to justify it and say everything's peachy. I also know that, sorry, I just wanted to say also that I know that there is a critical shortage of methadone this week, and we have, my hospital has been providing methadone to 2 or 3 pharmacies in our area this week, and I'm aware of some emails from another local health district, 5 o'clock this afternoon. So this is a key issue. Medication can be requested from local health district, and they have a system in place that is a bit controversial at the minute, but there is a system in place to transfer or to loan a bottle of methadone should that be required.
Can I just respond to the shortage of methadone?
Yeah.
We have intel that the shortage of methadone is due to a logistical error, not a logistical change, sorry, not a logistical error. We've been told that tomorrow that the shipments will be going out. And Christina, how many, it was like 75% of shipments, was it? That would be
I'd have to double check the email because it just came out this late this afternoon. But we've been advised that it will be rectified shortly.
Christina, it's Ruth Martin. It was 70%, and they will be distributing stock based on historical usage to try and avoid the situation where some people have been stockpiling.
Yeah, great.
Doesn't help the patients on the south coast of New South Wales that don't have methadone tomorrow. But
yeah, Symbion also said they'll also have a large stock of 200 ml bottles in. Again, that doesn't help tomorrow because it'll be at least Thursday before it will reach regional New South Wales.
It takes 2 or 3 days to get through the chain.
Yeah, absolutely it does. I'm in regional New South Wales as well, Andrew. So that's yeah, but that's where that's got to.
But that's all right because I'm going for a long drive tomorrow. So
I think, but the issue, the critical shortage has been escalated through to the ministry from all sorts of people, and everyone's working on a solution. The next person, we've got 2 hands are up, so I'd like to turn to Michael Troy if your hand is still up, but you're on mute, so please unmute yourself.
Yes, indeed. Thank you very much. Look, as a community pharmacist, community pharmacy owner, I just wish to wholeheartedly reiterate everything that Andrew just said just then, to add gravitas to the situation in pharmacies. Excuse me, saw a recent survey published by the Pharmacy Guild, which showed some huge number of pharmacists and pharmacies who were looking to vacate this area of practice. I saw one of my local prescribers on, Trish, don't worry, I'm not getting out of it. I've said that to you before. But it's certainly a concerning situation there for the whole area. And I think it's also coming at a time in the community pharmacy with the talk and implementation of the 60-day dispensing and the fear of the revenue lost through the dispensing chain that is often has been historically used to cross-subsidise so many services and pharmacies. And this is just another nail in said coffin for pharmacies, where we might have done the opioid substitution program as a loss leader, as a community service, which, hey, we're not in it to become millionaires in this realm, but it's just another nail in said coffin for pharmacies again. So just vocalising what Andrew said and the concerns myself and many others do have in this realm, in this sphere.
I've heard about this, the storm, the twin storm of the 60-day rule and the changes here. I've heard about it from several pharmacies. I acknowledge that that's a big issue. I also think that there's a hump here of a new, complicated and confusing process to follow. But once we get used to it, My fingers are sort of mildly crossed that we'll get used to it and I'd say laugh about it one day. I'm not sure that day will be very soon, but that's what I'm hoping.
I'm pleased your fingers are crossed, Paul.
Well, I'm an optimist by nature, I guess. I turn to Jalal Chami and ask, yes, you're off mute. Thank you. Your turn.
Thanks, mate. Again, I also am a pharmacist, own a pharmacy in Parramatta. I have over 100 patients at the moment on the program. And again, I reiterate the previous points by John, Andrew, and Nader before me. The fact that we're having a webinar where there's still so many questions remain unanswered, and the more I listen and the more I see some of the questions and feedback on the chat, the more I realize how big the issue is. And I understand these are sort of the pains going through transition. The question I'm asking is, why does it have to be the 1st of July? Why does it have to be that 10 days from now, we must do this? Why can't it be postponed till 1st of August, have increased the level of awareness by prescribers, by pharmacists, by patients, and by the logistics side. Even a mistake on the methadone is leading to consequences on the ground. It's actually affecting people. Sometimes are not able to dispense dose methadone for patients because someone changed the PBS code. Like, this happens because it was forced. Someone decided that 1st of July is D-Day. Why? No one knows, but it's D-Day. I'm still at odds to go, why? Why can't it be? Yeah,
look, of course, this is a Commonwealth decision, and we have to live with it. Any time that's change, it's going to be hard, but I don't know that the people that made the decision really understood the complexity of this treatment. I think if you put, for example, a new antibiotic on the PBS, you decide how much it's going to cost, and if you agree with the financial argument, away you go. Whereas here, the opioid treatment program is far more complex. It's not just about the medication, of course, and I don't think they got it right. What can I say? That said, our job both tonight and otherwise is to navigate the system for ourselves and our patients, and I believe it can be done. It's going to take some effort, and it's going to, there's going to be a bit of frustration here and there, but it can be done. I think it's frustrating for community pharmacy. I think there are some clinical settings like the private clinics that are going to find it very hard, but I think the chemists, the only thing I'd say about the money side of it is to keep in mind is that although the paperwork is very complicated for the PBS, you do get paid, and it is easier to argue with the government than some of the patients. So I think the reliability of being paid is going to go up a bit. Thomas, yeah?
I was going to say, just regarding the money, it's not the money that we're thinking of. Virtually most pharmacies that I'm talking to are getting a small decrease in payment, a significant increase in paperwork and complexities and delay in payment, cash flow, effect. And a lot of uncertainty for, again, I'm baffled as to who decided that 1st of July, and can we have the reasons why? Yes, we can do it, but why do we have to go through significant pain to do it when we can actually plan it properly and do it at just a month later? Nothing will happen. The patients will remain patients. And
I think, honestly, changing that date is beyond capacity of New South Wales Health. Even though we have some senior people here, this is not within their wheelhouse, I'm afraid. So I share your frustration, but I think we can't respond more than that. And I'll just move on to our next question, which is Thomas Liu.
Hi, Paul. Thanks for having the webinar. I just got two questions. I think firstly, what is the rebate for pharmacies for dosing patients? Is it going to be fairly similar to what
Yeah,
is
it's
currently being charged?
yes.
And then secondly, are we talking about depot buprenorphine at all tonight?
Yes, so I can answer those questions. The proposed fee for the pharmacies is broken up into subdivisions, and you add them all up. It is in the range of what most pharmacies are charging, and that means it's less than some of them are charging. And as Jalal and others have said, it comes at a cost in terms of paperwork and complexity. So, but the revenue will be reasonably similar per patient per week for methadone. Now, you ask about buprenorphine. Buried in there is a specific administration fee for a pharmacist to provide the depot injection. We know that in some parts of New South Wales, particularly Hunter, New England, there's been pretty healthy uptake of depot buprenorphine by pharmacies. In other areas of Sydney, very limited. And Ministry has been supporting a pharmacy program for administration of depot, nothing to do with the PBS, but because it's good practice and a good idea. And that has been going for approximately a year, and that's had variable uptake as well, but there have been air pockets where it's been quite well received. So there is both training and encouragement for pharmacists to get on board with administration of depot buprenorphine, either of the two brands that we currently have.
Thanks so much, Paul. That's really helpful. Can I just ask, in follow-up to that, for clinicians who are doing depot buprenorphine in their clinics where they get the drugs delivered directly to their clinics, I think that the S100 changes will make that process quite difficult with some clinics. Is there a way to bypass the increased paperwork, I guess, that's going to be associated with this?
So the Sublocade and Buvidal makers have been encouraging GPs to order in medication and give to their patients directly, which in a sense means no pharmacy at all. I don't think that's been a massive program, but it does occur. And my clinic does it a bit, and I know others do. So it's non-zero. And under the and up till now, the medication has been available free, and the administration has been covered either by charging the patient money or the doctor doing it as part of their MBS claim, as the part of their clinical encounter. So under moving forwards, that arrangement will be allowed to continue till the 30th of November as the transitional arrangement. So you can carry on. But after the 30th of November, it's off. It's over. So after the 30th of November, you either make an arrangement through a PBS pharmacy, and this was covered by the most recent fact sheets released last night. You either make an arrangement with a PBS pharmacy for the patient to receive their injection in that pharmacy, or dispense through that pharmacy into a doctor's surgery who can then give the injection. You do have those choices. And to the best of my knowledge, those are the only choices that are going to be made available.
Thanks, Paul.
Nader?
Yes, thank you. My last question from me anyway is really around the PRU and the substitution of methadone and biodone. As Andrew touched on earlier, many pharmacies have either already run out of methadone or will run out tomorrow. We are getting conflicting advice from the PRU whether we can automatically substitute to biodone. I have the clinic here in Newcastle who said, yes, we can.
Yeah.
But like many of us have mentioned, we need to make sure that our legislative requirements, and we're not breaking any laws, are, we dotted our I's and crossed our T's. So are we able to get confirmation once and for all whether this can be substituted or not?
Well, as a doctor, yeah.
There's no one on from PRU on the call, but I can absolutely find out definitively from the head pharmacist whether it's okay. I know what you're going to say, Paul, and I would agree with you, but I can make a call and find out, and we can potentially email or get Daniel. We can send an email to Daniel to email everybody.
That would be fantastic if we can disseminate some information. The sooner the better. But I suppose the follow-up question would be, if the answer is no, and we don't have methadone, what am I to tell those patients?
In all honesty, if they say you can't substitute, you can get a fresh prescription for what you do have, because they are, of course, two preparations of the same medication. So worst case scenario, if someone says you can't substitute, you can you can ask the doctor to cancel the script and reissue a script for the medication that is available. I have to say, I understand that could be quite a burden, and I'm sure that we're all incredibly reluctant to go through it. So I'm kind of hoping that Steph is able to get advice that says what we want to hear. But that you've asked me the worst case scenario, I think that would be at least it's a bad solution, but it's a solution.
Okay.
Paul, can I just quickly chime in on that, because I spoke to PRU shortly before this meeting, and they called me specifically about that. And I want to make sure that we get kind of written confirmation from them, but I can say, based on the conversation I had, it should not be a problem with the substitution.
Christina and Paul, it's Ruth Martin. I've already, while we were talking, emailed Bruce Batty to get that confirmation, and I hope he'll come back with that tomorrow morning, and I'll send it out through Daniel and Christina.
Okay, thank you.
Sorry, can you hear me?
Well, who is that?
Stuart Luddington.
Yes, but there are three other hands up.
I can clarify this for you straight away if you like.
Oh, okay.
So I work for PRU. I have recently, this evening, received an email, and I'll read it to you.
Yeah.
Let me just bring it up here. It has been brought to our attention that many pharmacists are inquiring whether a new prescription is required, switching from one brand of methadone to another, both 5 milligram per mil. Please advise there need not be a new prescription written for this purpose, as the case for medicines of the same strength and multiple brands.
Right. Okay. Well, and who signed that email?
The acting director of the Pharmaceutical Regulatory Unit, Monique Reyes.
I just looked, Stuart, and I've got the same email as well. So that confirms that yes, you can.
That's fantastic. Thanks, Stuart.
Thank you. And I hadn't seen that, but that's great. And thank you for butting in with the answer to it.
Yeah, look, I'm sorry to butt in, but
No.
Sometimes it's better to impose yourself.
Now,
thank you, Stuart. Thank you.
Now, look, we are at the end of our time. There are two hands up. I'm going to ask that we hang on and allow those two people to ask their questions, because they've been very patient, but super fast. Teresa?
Hi. I just wanted some clarification about patients that are over 150 milligrams of methadone, because on the program it says that it covers for patients up to 150 milligrams, but we've got a couple of patients that are over that dose. So what do we do with their script, or what does it? Yeah, I'm just a little bit confused. That's all.
Yeah, you're supposed to get a telephone authority for higher doses.
Right. So in the interim, though, would we just re-dispense their current paper script on the 1st of July, and with as usual, and then the doctor can organise a new telephone authority post the 1st of July?
That's right. Because that's right.
I'm just trying to get my head around it. So okay.
And Teresa, I believe the fact sheet for prescribers also provides advice on how to handle scripts that are over 150 milligrams of methadone that were provided prior to 1 July. So I think,
Okay.
yeah, definitely
Okay.
encourage checking that fact sheet.
Okay, thank you.
And Frank McLeod, lucky last. Frank, the hand is up. You're on mute. I'm going to count to 3 because it's 7:03. I think Frank might have.
No, there we go.
Yeah,
Sorry.
okay.
Two things. One is I think the confusion about biodone versus methadone syrup is best clarified if you write all your scripts as methadone liquid, as it covers both forms, and that's been confirmed by the PRU. And the other thing is, if we are short of methadone, what about the possibility of using phiseptone tablets in the interim without the need to having to apply for a separate S8 authority, which the current rules require? But it'd be a fallback position.
Well, I hear what you're saying, but I think there seems to be other solutions that are operating. And
except, Paul, I'm in the South Coast and everyone's saying that this is a place that I think it was Andrew was going to drive down and rescue people tomorrow. I've got a pharmacist locally driving to Wagga to borrow from his brother pharmacist there. I mean, our area is in major issues. We've got people now that have lost all their takeaways because they're being managed day by day. And phiseptone tablets would be a fallback position if the brown stuff hit the revolving object.
yes, I think that if you have no other solution available to you, you would have to escalate that. Or, yeah, you'd have to contact to get advice about whether that would be approved on an interim basis. If there was a genuine shortage, there has been a genuine shortage, but if there's a continuing shortage, because we've also been told that this deliveries are going out tomorrow and the shortage will be over, and we're getting conflicting messages. So I think if there is an unresolved critical issue, you can escalate that through either PRU, through your public sector staff specialists and public sector drug and alcohol service, or through the Centre for Alcohol and Drugs for advice. And I know that's potentially 3 or 4 phone calls and quite tedious, but if we follow through, we'll get a solution in place. Steph, did you want to add anything?
I just want to acknowledge the complexities of the environment that we're all in, and acknowledge how challenging it is for the private clinics, for the non-PBS pharmacies, for the pharmacies. And thank you for being so open and candid tonight. This has definitely opened my eyes to some of the issues relating to pharmacies and why pharmacies are choosing to either reduce the number of people that they dose or opt out altogether. Hopefully we can work together to work towards solutions, and thank you for bearing with us through the transition, and we'll get information to you as soon as we have it.
Thank you very much, Stephanie. I think this has been a great session, if nothing else, to help us understand the problem and to suggest some solutions where they can. Again, look at in terms of PBS and community stuff, look at these cheat sheets, FAQs as they come through. There probably will be more updates. And I'm going to close the session and thank everyone for their participation. More than 200 people still online. So hell of a lot of interest in this topic. And thank you very much for your time, and good night to all.